Hi, this is the first lecture in the anatomy of upper extremity. A good source that you can use is this book written by myself. We're going to start with some approaches of the shoulder. So there is the posterior approach for the glenoid. So if you would like here to do some fixation for the glenoid, like this example here, an X-ray with glenoid fracture that we did an internal fixation, you need a posterior approach to the glenoid, and this posterior approach to the glenoid is going to be between the infraspinatus muscle and the teres minor muscle. So it's between the infraspinatus and the teres minor, and this will take you to the posterior glenoid and the posterior capsule. Remember, the teres minor muscle is supplied by the axillary nerve. The infraspinatus is supplied by the suprascapular nerve. This is the interval here, and this is a true interneural plane. The infraspinatus supplied by the suprascapular, the teres minor supplied by the axillary, and the retraction of the teres minor is what's going to protect your axillary nerve. So the structure that is at risk in this approach is the axillary nerve, and it is protected by the teres minor muscle. If the aim of the surgery is to reach to the posterior capsule, you can use the infraspinatus splitting. That means that you go through the infraspinatus muscle. That will take you directly to the posterior capsule, and it will be less chance of injury to the axillary nerve. Remember, excessive superior retraction of the infraspinatus will put traction on the suprascapular nerve and artery. Remember, the teres minor muscle, as we said in that classic approach between the infraspinatus and the teres minor, is supplied by the axillary nerve, which goes below the muscle. So when you retract this muscle down, as you can see here in this approach, this muscle will be the protector for the axillary nerve. This is the quadrangular space that we're going to take after a few slides, and it has the axillary nerve and posterior circumflex humeral vessel, and the approach is here between the teres minor, this muscle here, and the infraspinatus. So the posterior approach to the glenoid neck, as you can use it sometimes for open reduction internal fixation, it's between the infraspinatus and the teres minor. Infraspinatus supplied by the suprascapular, teres minor supplied by the axillary. The axillary goes below the teres minor. The suprascapular nerve comes from above the infraspinatus, so you retract this superior and retract this inferior. If you're mainly interested in going to the posterior capsule and not the glenoid, you can go do infraspinatus splitting, which will be further away from the axillary nerve and artery. And always avoid excessive superior traction, as this may cause injury to the suprascapular nerve. In approaches of the shoulder, the acromial branch of the thoracoacromial artery, frequently encountered in questions. We have the axillary artery. The axillary artery will give the thoracoacromial artery, and one of the branches of the thoracoacromial artery here is the acromial branch. So the acromial branch of the thoracoacromial artery, it will cross the upper part of the deltopectoral groove just distal to the clavicle, and this can be injured during anterior approaches to acromion or anterior branch to the shoulder. So if you get a scenario that describes that you are doing anterior approach to the shoulder or the acromion, and there was all of a sudden bleeding, what is the responsible artery? It is the acromial branch of the thoracoacromial artery. So again, the axillary artery will give the thoracoacromial artery, and one of the branches of the thoracoacromial artery is the acromial branch, and this will pass in the superior part of the deltopectoral groove just distal to the clavicle, and in anterior approaches to the shoulder or the acromion, it can be injured, and it frequently comes in the scenarios in the exam. So one of the important approaches in the shoulder region is the deltopectoral approach. We use this frequently in surgeries for the proximal humerus. whether open reduction tendon fixation or arthroplasty. The deltopectoral approach is between the deltoid muscle laterally, pectoralis muscle major. In order to reach to the shoulder joint, the subscapularis muscle will have to be either cut or osteotomy of the lesser tuberosity, and this has to be repaired at the end to maintain the internal rotation. So if this was done to reach the shoulder joint, cutting the subscapularis or doing lesser tuberosity osteotomy, there will be restrictions in both active internal rotation and passive external rotation more than 90 degrees to avoid failure of the repair. So the deltopectoral approach between the deltoid muscle laterally, pectoralis muscle, pectoralis major medially, and then if you will work on the proximal humerus, that will be enough. If you want to approach the shoulder joint, as in a shoulder arthroplasty, there will have to be cutting the subscapularis tendon or osteotomy of the lesser tuberosity, and this has to be repaired at the end, either repair the tuberosity or repair the tendon. And once you do that, you will have to limit active internal rotation and limit also passive external rotation beyond 90 to avoid failure of the repair. Another also common approach in the shoulder is the lateral deltoid splitting. That's used in some cases of proximal humerus fracture, in which you do, instead of going here anterolateral or anterior in the deltoid, in the deltopectoral interval, you can go directly lateral here in the deltoid splitting. So you will go through the deltoid. However, you cannot extend this incision without preservation of the axillary nerve. So the axillary nerve is about 5 centimeters from the acromion. So you either limit the incision to this area, or if you want to go more distal, you will have to find the axillary nerve so that you don't injure the axillary nerve. So deltopectoral approach and lateral approach, which is the lateral deltoid splitting. Beware of the axillary nerve in the lateral approach. The distance between the nerve and the lateral margin of the acromion is about 5 centimeters, and you either limit your approach to that, or if you want to extend more, you have to identify the nerve. The axillary nerve in this area is more of threads rather than like one single nerve. So you identify the bundle, and then you can go distal if you want, like passing a plate. You can pass it under the nerve. The posterior approach to the humerus is very important approach in open reduction tendon fixation. There is two types, the traditional posterior triceps splitting and the modified posterior approach. The traditional one, the triceps splitting, we do the skin incision, we identify the nerve, and then we split the medial head of the triceps. You can also mobilize the nerve and reach part of the humerus proximal to the nerve. This exposes about 60 to 65% of the humeral shaft. There is the modified posterior approach. In the modified posterior approach, you will not split the medial head, as you can see here. And what you will do is you will mobilize both the medial head and the lateral head of the triceps. You will mobilize them from lateral to medial direction. So you will mobilize them from lateral to medial direction. So you will move them from this part to this part. You will mobilize them from lateral to medial, and this can expose about 95% of the humeral shaft. So two types of posterior approach. This is the traditional. You open, you identify the nerve, you split the medial part. You can reach some part of the humerus that is proximal to the nerve. In the modified one, you don't split here. You go, you raise the medial head and you raise the lateral head from lateral to medial direction, and you can reach much bigger and larger part of the humerus, about 95% of the humeral length. And now we're going to speak basically about one of the most important topics in anatomy, which is the brachial plexus. Brachial plexus is by far the most important anatomical concepts that come in the orthopedic exams. It is extremely important, and everything in this graph, which is from my book, can come in your exam. You need to know it by heart. You cannot cut corners in this. You have to know every single thing in this graph, and you need to understand brachial plexus and memorize it very good, because it will come in multiple questions in your final exam, and it's also very important in the clinical practice. So what is brachial plexus? Brachial plexus is the innervation of the upper extremity. It's a plexus that is formed by roots, trunks, division, cords. Remember, roots, trunks, division, and cords. So what roots are involved in the brachial plexus? It's from C5 to T1. C5, 6, 7, 8, and T1. Remember, there is something called C8. We have 7 vertebrae, but there is 8 roots, because there is one root that comes above C1, and then it continues to C7 above C7, and then C8 below C7, between C7 and T1. So there is a C8. So roots are 5, 6, 7, 8, and T1. You have 5 roots. So brachial plexus, you have 5 roots: 5, 6, 7, 8, and T1. And now we'll go to trunks. So the trunks of the brachial plexus is formed from the roots. So trunks are formed from the roots. So root 5 and 6 will give the upper trunk. C7 will continue as middle trunk. Okay, so C7 will continue by itself. It's not combined with other one. 8 and T1 will give the lower trunk. So first thing is the root: 5, 6, 7, 8, and T1. Followed by trunks. 5 and 6 will give upper trunk, 8 and 1 will give lower trunk, C7 will continue as middle. Roots, trunks. After that is division. Each trunk will split into anterior division, posterior division. So we have anterior division of the upper trunk, posterior division of the upper trunk, anterior division of the middle trunk, posterior division of the lower trunk, of the middle trunk. Anterior division of the lower trunk, posterior division of the lower trunk. So each trunk will give 2 divisions, anterior and posterior. Again, roots: 5, 6, 7, 8, T1. Trunks: upper, middle, lower. 5 and 6 will give upper, 7 will continue as middle, 8 and T1 will give lower. Each one of the upper, middle, and lower will give anterior division and posterior division. Now there's the cords of the brachial plexus. Okay, the cords of the brachial plexus: posterior cord of the brachial plexus is formed by the posterior division of all 3 trunks. So the trunks, each trunk will give anterior and posterior. Very easy, all the posterior will form the posterior cord. The anterior division of the upper and middle will continue as the lateral cord. The anterior division of the lower will continue as the medial cord. So again, roots, trunks, division. We have 3 anterior and 3 posterior. The 3 posterior, very easy, will form the posterior cord of the brachial plexus. Anterior of the lower will continue as the medial. Anterior of the lower will continue as the medial, while the anterior of the upper and the middle will form the lateral cord. So we have 3 cords: posterior cord formed by the 3 posterior division, medial cord formed by the anterior division of the lower trunk, lateral cord is formed by the anterior division of the upper and middle. So again, we have roots: 5, 6 will continue give you the upper trunk, 7 continue at the middle trunk, 8 and T will form the C8 and T1 will form the lower trunks. Remember, these are trunks. And then there will be division, anterior and posterior. And then there is cords. So roots, trunks, division, cords. Don't mix trunks and cords. Trunks is upper, middle, and lower. Cords is lateral, posterior, and medial. The anterior division of the lower will continue as the medial. Anterior division of the upper and middle will continue as the lateral. Posterior division of the 3 trunks will give the posterior cord. So now, after we discussed the roots, trunks, divisions, and cords, we would like to discuss the terminal branch. Terminal branch and the brachial plexus can come from the roots, can come from the trunk, or of course mostly they come from the cords. From the root, we have one nerve, which is the long thoracic nerve, or the nerve to serratus anterior. It comes from 5, 6, and 7. 5, 6, and 7 will give the long thoracic nerve, or nerve to serratus anterior. From the upper trunk, there is two nerves, the suprascapular nerve and nerve to subclavius. This area here is called the Erb's point. An injury to this causes, of course, the classic Erb's palsy, which we will discuss in the pediatric orthopedic lectures. So this area here is called the Erb's point. So the upper trunk gives two nerves, suprascapular nerve and nerve to subclavius. And now, as we said, most of the terminal branch will come from the cords. From the lateral cord of the brachial plexus, we will have three nerves: lateral pectoral nerve, musculocutaneous nerve, and branch to the median nerve. So the lateral cord of the brachial plexus will give three nerves: lateral pectoral nerve, musculocutaneous nerve, and branch to the median nerve. The posterior cord of the brachial plexus will give 5 nerves: upper and lower subscapular nerve, thoracodorsal nerve, radial nerve, axillary nerve. So the posterior cord will give 5 nerves: upper and lower subscapular, thoracodorsal nerve, radial nerve, axillary nerve. The medial cord of the brachial plexus will also give 5: medial pectoral nerve, medial cutaneous nerve of the arm and the forearm, ulnar nerve, and branch to the median nerve. So lateral cord gives 3, posterior cords give 5, medial cord give 5. Remember, the median nerve has contribution from the lateral cord and from the medial cord. So let's discuss these terminal branch again. Lateral cord will give, as we said, 3: lateral pectoral nerve, musculocutaneous nerve, and a branch to the median nerve. Posterior will give 5: upper and lower subscapular, thoracodorsal, radial, and axillary. Medial will give 5: medial pectoral nerve, medial cutaneous nerve of the arm and the forearm, ulnar nerve, and branch to the median nerve. So remember, the lateral pectoral nerve from the lateral, the medial pectoral nerve from the median. Median takes branch from the lateral cord and medial cord. Lateral will continue as musculoskeletal. Posterior will continue as radial and axillary. Medial will continue as the ulnar. Another important anatomic relation in the arm is the 3 spaces: quadrangular space, triangular space, and triangular interval. Always remember that the spaces are up and the interval is down. So the 2 spaces that are above the teres major are called spaces. The one below it are called interval. So remember, we have space, space, and interval. Spaces are above and interval is below. So what is the quadrangular space? Quadrangular space is a space between the long head of the triceps, this muscle here, the long end of the triceps, the teres minor, the teres major, and the humerus. So it is a quadrangular space between long head of triceps, the humerus, the teres major, and teres minor. So what is in the quadrangular space is the axillary nerve and the posterior circumflex humeral vessel. There is another space. Remember, spaces are above teres major, interval is below. Another space is the triangular space, and this between teres major, teres minor, and long head of triceps. It has the circumflex scapular vessel. There is the triangular interval. So this is called space. As we know, space is above, interval below. The interval has the radial nerve and the profunda brachii. It is formed by the long head of triceps, the lateral head of the triceps, and teres major, and it has the radial nerve and the profunda brachii vessel. So I want you to remember, think that the teres major and the long head of the triceps muscle are both in the 3 spaces and the interval that we described. So as you can notice, the teres major and long head of triceps, they form boundaries in all these spaces and interval. So the teres major is the lower border of the quadrangular space, triangular space, and the upper border of the triangular interval. The long head of the triceps is the medial border in case of quadrangular space and the triangular interval, and it is the lateral border in the triangular space. Again, remember, spaces are above, interval is below. The quadrangular has the axillary and the posterior circumflex humeral. The triangular interval has the radial nerve profunda brachii vessel, while the triangular space here has the circumflex scapular vessel. Now we're going to talk about the rotator interval, very important topic, and it comes frequently in the exam. The rotator interval has contents and boundaries. We're going to speak about them now. The rotator interval is like a triangle. The base of that triangle is the coracoid process. The apex is the humeral ligament, the transverse humeral ligament over the biceps tendon, where it goes between the intertuberculous sulcus. So this is the apex here, the transverse humeral ligament, and the base is the coracoid process. The superior border of the rotator interval is the anterior border of the supraspinatus. So here is the supraspinatus. The anterior border is the superior boundary of the rotator interval, while the inferior boundary of the rotator interval is the upper border of the subscapularis muscle, as you can see here. So upper border of the subscapularis, anterior border of the supraspinatus, the base here is the coracoid process, and the transverse humeral ligament over the biceps tendon at the intertuberculous sulcus. These are the boundaries of the rotator interval. Now we're going to talk about the rotator interval, very important topic, and it comes frequently in the exam. The rotator interval has contents and boundaries. We're going to speak about them now. The rotator interval is like a triangle. The base of that triangle is the coracoid process. The apex is the humeral ligament, the transverse humeral ligament over the biceps tendon, where it goes between the intertuberculous sulcus. So this is the apex here, the transverse humeral ligament, and the base is the coracoid process. The superior border of the rotator interval is the anterior border of the supraspinatus. So here is the supraspinatus. The anterior border is the superior boundary of the rotator interval, while the inferior boundary of the rotator interval is the upper border of the subscapularis muscle, as you can see here. So upper border of the subscapularis, anterior border of the supraspinatus, the base here is the coracoid process, and the transverse humeral ligament over the biceps tendon at the intertuberculous sulcus. These are the boundaries of the rotator interval. So this is the rotator interval here, as we said. So we have boundaries and contents boundaries. Anterior border of the supraspinatus, superior border of the subscapularis, coracoid process, transverse humeral, and the contents long head of the biceps, and the coracohumeral and the superior glenohumeral ligament. Remember, this interval is in the anterior superior part of the joint. When a tight closure of the rotator interval will decrease the posterior-inferior translation of the humerus in relation to the glenoid. So it is the antero-superior part. So if it's tightly closed, it will result in reduction of the posterior-inferior translation of the humerus in relation to the glenoid. The shoulder joint has a strong ligaments that maintain the stability of the joint. The coracohumeral ligament and the glenohumeral ligament. So the coracohumeral ligament goes from the coracoid to the humerus, and as we said, it's part of the rotator interval, and it is the primary restraint for inferior translation of the shoulder. So it prevents inferior translation of the shoulder. There is also the glenohumeral ligament, the superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral complex that has different function. The superior glenohumeral ligament also is a primary restraint for inferior translation with the arm in adduction. So that means that both coracohumeral ligament and the superior glenohumeral ligament. Both prevent inferior translation of the arm, and both, as we said in the previous slide, components of the rotator interval. So coracohumeral ligament, rotator interval, superior glenohumeral ligament, also in the rotator interval. The coracohumeral is the primary restraint to inferior translation of the shoulder. The superior glenohumeral is the primary restraint for inferior translation of the shoulder with the arm in adduction. So we discussed the superior glenohumeral. The middle glenohumeral ligament. Middle glenohumeral ligament prevent anterior and posterior translation in the mid-range of abduction. So it prevents anterior and posterior translation in the mid-range of abduction, which is 45 degree, and with 90 degree abduction, the anterior band of the inferior glenohumeral, prevents the anterior translation, while the posterior band will limit posterior translation. So superior glenohumeral ligament, that's prevent inferior translation with the arm in adduction. 45 degree, the middle glenohumeral will come into action, preventing anterior and posterior translation. The inferior glenohumeral ligament, the anterior band will prevent anterior translation, 90 degree abduction, and the posterior band will prevent posterior translation. So for the glenohumeral joint in the mid-range of motion, the most important stabilizing mechanism is actually what's called concavity compression. It means that the humeral head is pushed against the concavity of the glenoid by the action of the rotator cuff, and this is the most important stabilizing mechanism for the mid-range of motion. Also with 90 degree forward flexion and elevation, as we know, the inferior glenohumeral ligament becomes an important stabilizing factor. So with that position and internal rotation, the posterior band of the inferior glenohumeral becomes the most important stabilizing mechanism. So with elevation 90 degree forward flexion with internal rotation, what will happen is the posterior band of the inferior glenohumeral will become tight, and it will become the most important stabilizing mechanism for the shoulder in that position. So the blood supply of the humeral head is also an important topic. Previously, the literature thought that the arcuate artery, the anterolateral ascending branch of the anterior circumflex humeral artery, is the primary supply for the humeral head. However, more recently, it is thought that posterior humeral circumflex artery actually gives 60% of the blood supply to the humeral head, and 40% are from the anterior humeral circumflex artery through its ascending branch, or the arcuate artery. I would like to review the nerve supply of the muscles around the shoulder. It's commonly asked questions in the exams. The axillary nerve supplies the deltoid and teres minor. So the axillary, we all know that the axillary nerve is the nerve supply for the deltoid, but we forget about teres minor. So if we discussed the quadrangular space, if you remember, in the beginning of the lecture, and the axillary nerve will go into that quadrangular space to wind around the humerus and go anteriorly. So when it goes into that quadrangular space, it will supply the muscle above it, which is teres minor, and it will supply after that the deltoid. This is very important. So the deltoid and the teres minor. The suprascapular nerve, we also know that supplies the supraspinatus and the infraspinatus. And then the upper and lower subscapular nerve, they supply the subscapularis muscle. Remember, the teres major muscle takes from the lower subscapular. So the teres major takes from the lower subscapular. So here is the teres major muscle. It does not take from the deltoid. It takes from the lower subscapular on the other side, on the anterior side. Remember, teres minor takes from the deltoid, it takes from the axillary nerve, similar to the deltoid here, and the teres major muscle, teres major, which is this muscle here, will take from the lower subscapular. So we're going to talk now about some of the joints around the shoulder, the sternoclavicular joint and the acromioclavicular joint and their stability. So for the sternoclavicular joint, the medial joint of the clavicle, most of the stability comes from the posterior capsule. So the posterior part of the capsule, which you can see here, this is the main stabilizer of the sternoclavicular joint. For the acromioclavicular joint, the anteroposterior stability comes from the superior capsule. So this is the acromioclavicular. There is vertical stability and anteroposterior stability. For the anteroposterior stability, the primary restraint is the superior capsule, and the most important part of the superior capsule is the posterior thickening. So the posterior superior part of the capsule, this is the main part for anteroposterior stability of the acromioclavicular joint. For the vertical stability, the most important part is the conoid part of the CC ligament. So the coracoclavicular ligament is two parts, trapezoid and conoid. The conoid part is stronger than the trapezoid part, and it is more medial and posterior. So as you can see here in this graph, this is the trapezoid and this is the conoid. So the conoid is posterior and medial. Remember, the coracoid process aims anterolateral. So what here is actually medial and posterior. So again, acromioclavicular joint has vertical stability. The most important part is the conoid part of the CC ligament, which is stronger than the trapezoid part, and it is medial and posterior. There is anteroposterior stability. This is controlled by the superior capsule, and the most important part of the superior capsule is the posterior part. So the posterior superior part of the capsule is the main stability for anteroposterior. The width of the insertion of the supraspinatus commonly comes in the exam because it actually has an important clinical implication, because it will affect the decision for surgery, as we're going to see in the shoulder lecture. So the width of the insertion, the mediolateral, so this is the head, it's medial, and then we're going lateral here. So mediolateral, it's about 16 millimeter. That's the footprint of the insertion of the supraspinatus into the bone. So if you're doing an arthroscope and you see an exposed 7 or 8 millimeter of bone lateral to the articular margin, so here's the articular margin, and you find 7 millimeter exposed bone or 8 millimeter, that indicates about 50% of the tendon is affected, and that's going to affect your decision for surgery. So it's about 16 millimeters. So arthroscopic measurement, arthroscopically, if you see 7 millimeter of exposed bone lateral to the articular margin, here's the articular margin. If you find 7 millimeter of exposed bone, that indicates about 50% of the tendon. As we discussed before, there is something called a concavity compression, which depend on the rotator cuff muscle, which basically means that the muscles pull the head against the concavity of the glenoid, and this is an important stabilizing factor. So as you can see here in this picture, the long head of biceps attached to the labrum in different position. Most common is this position, which is predominantly posterior, meaning it arises from posterior and anterior, but it's predominantly posterior, followed by entirely posterior, followed by equal anterior and posterior. So this is the most common, in predominantly posterior, followed by entirely posterior, followed by equal anterior and posterior. The least form is predominantly anterior. Also, the long head of the biceps is controlled in the biceps groove by the biceps pulley. The biceps pulley is formed, as we talked in the rotator interval, by two ligaments, which is the coracohumeral ligament and the superior glenohumeral ligament. So this pulley here by the two ligaments, coracohumeral ligament and the superior glenohumeral ligament, prevent the subluxation, especially medial subluxation of the biceps tendon. Now let's study the biceps tendon after it goes in the groove. We need to know first the attachment of the muscles in the groove. Pectoralis major attaches laterally, teres major medially, and the latissimus dorsi in the floor. So pectoralis major is more superficial. It will come and it will attaches laterally here. And then we have two muscles. The teres major will attaches medially. It is the most deep structure. And then we will have latissimus dorsi muscle will have a triple relation to teres major, will come posterior and then inferior and then anterior. It will attaches to the floor. So always remember the two lips attached with major, lateral lip pectoralis major, medial lip teres major. The floor is with the latissimus dorsi muscle. So two major muscle and in between them is the latissimus dorsi. Laterally is pectoralis major, medially teres major, and in the middle is in the floor will be latissimus dorsi. So when the biceps tendon will go into that groove, it will be medial to the pectoralis major. Pectoralis major will be lateral to it, and it will be lateral to the latissimus dorsi and the teres major muscle. So quickly again review, the biceps will go through the biceps bulli by the two ligaments, coracohumeral and superior glenohumeral. It will go into the groove. Lateral to it will be the pectoralis major, which will attaches to the lateral lip of the biceps groove. Medial to it will have two muscles. The teres major attaches to the medial lip of the biceps groove, and the latissimus dorsi muscle, which will attaches to the floor. I hope this lecture and the rest of the lecture will help you in your clinical work and your exam. Thank you.